First thing I want to do is thank all of you for taking time out of your busy day and schedule to come up and hear what we have to say. I really appreciate your time. As folks know, we have been embarked for the last year on a strategic planning process. The main driver of that initiative was the fact that we were concerned about our critical access hospital designation. We felt as though that designation was in jeopardy and that would have some significant problems for the organization. What we learned as we went through this planning process is that there are other issues that we need to be aware of. Those of you who have heard me talk in the past know that we talk a lot about the fact that the United States healthcare system, very, very expensive. It doesn't deliver on quality and excludes a whole lot of people. The main parts of the ACA are coming on board this year. That we hear a lot about how that's impacting patients, but the reality is it's impacting us as healthcare providers as well. And we know that there is a lot of momentum for change in the healthcare industry. And so as we worked through the plan, we recognized that we have to respond to all that change that's coming our way. When we started this effort, the overall charge for the strategic planning effort was to set APD on a path for financial sustainability. So we had a global aim of let's make sure that we are able to survive financially into the future. Because we were worried about our critical access hospital designation, we also had a specific aim to be ready to live without that designation by January 1, 2015. This plan was pulled together and presented to the Board of Trustees at the December meeting. It was endorsed and approved, and so this, what you're going to see here today is our marching orders from the Board of Trustees. Just to review the process that we went through with respect to our planning efforts, we had 6 task forces that we assembled. Each task force had a specific charge and was made up of a number of people from the senior leadership team, the medical staff, the directors. Some of our task forces had community members. Some of them had staff members. They each had a specific charge. We looked at our management service organization, which is the back office functions of the hospital. We took a good look at our multi-specialty clinic, and what that was looking at was our physician-owned practices. We think of ourselves as a hospital, but the reality is that probably 85% of what we do happens in the outpatient setting. So our physician-owned practices are a very significant piece of our organization. We wanted to take a deep dive and see what we could do to figure out how best to position those clinics for success into the future. We also took a good look at our occupational health services. Our Business Health Initiative Task Force was charged with figuring out how we can better partner with local business owners to deliver health care to employees. So is there opportunity for us to come together as a community to provide for health care needs through employment? We also took a good look at life care meaning Harvest Hill, Woodlands, Elizabeth Hughes Care Unit. This is a health system plan, and so we spent some time talking about life care. When it came to the hospital proper, we decided to split into 2 task forces. One drilled down and looked carefully at our OB services, and the other looked sort of at everything else. In all, there were over 40 people involved in these task forces. The Board of Trustees was kept informed at every step of the way. So I think in total we had over 60 people that participated in the development of this plan. It was not done hastily, and it was not done without a lot of input from a lot of people. So this is a plan that we believe has a lot of depth and breadth to it, and we feel confident that it will guide the organization for the next 3 to 5 years. The plan builds on some key themes. Number one, as we went through this, we really came to appreciate and understand just how much this community values Alice Peck Day. We came to appreciate that it is a community asset, a community resource, and that any plan that we came up with really needed to consciously preserve this organization for future generations. It is not our organization, it's the community's organization, and we need to ensure that it's here for multiple generations. We also felt strongly that we wanted to have minimal impact on all of you. We did not want a plan that re-engineered the organization at the expense of half of our workforce. That to us would have been a failure of a plan. We needed to ensure that we had minimal impact on you all as our employees, minimal impact on the people who live here at LifeCare, and minimal impact on our patients. We want to be able to say to our patients, if you get your care here and you're happy and satisfied getting your care here, we're going to be here and you can continue to see us over time. We also figured out that we deliver the right niche of services. There was nothing as we went through the planning process that we said, oh, we shouldn't be doing that, or gee, I wish we did that. We've already carved out our niche. And so while we recognize that the organization has to change because the external environment is changing, we also really feel strongly that as a starting point, we need to build on what's here. So we created a plan that preserves our existing service lines. The things that we do today, we anticipate doing for the next several years. There will be changes, but it will not be a dramatic blow-up kind of change. We expect evolutionary and gradual change. This plan builds on our core ideas, which we've been talking about now for quite some time. As a healthcare system, we have an obligation to improve quality, decrease cost, and expand access for the patients that we serve. These are the three big drivers, and so this plan, these ideas are woven into this plan. We absolutely must do this. Our current healthcare system is unsustainable, and change has to build on these three levers. I'm going to start by sort of running through the task forces and get you through the thinking and the high points from each of the task forces. There is a lot to this plan, and I do anticipate that you will be hearing more and more about the plan as the year unfolds. Purpose today is really to give you the high-level view, the bullet points, if you will, so that you understand the global strategy and where we're going. You will hear more details as it unfolds. With LifeCare, we feel strongly that we want to adopt a strategy that we call aging in place. What we learned is that most people, as they age, do not want to transition to residential facilities. They don't want to end up in nursing homes. People want to remain a vibrant part of their community. And we need to figure out how we support an aging population so that they can stay in their preferred place as they grow older. And so starting with the premise, the strategy of how do we support a concept of aging in place, we first looked at our residential facilities, Harvest Hill and Woodlands. And what we recognized was that there was more that we could do to support the people who are living in the apartments here, and that we could bring services to them through our existing home health agency. We do have a home health agency that's based at the Woodlands, but we think that we can build that out with a much greater scope of services, and that the idea is that as people age, their needs change. Instead of moving the person to a facility that better meets their needs, we bring services to them in their apartments that meet those needs. So that is something that we will be working on, and in fact have already started to work on as we are unveiling this plan. The other piece of the Life Care Strategic Plan that we are very excited about is the Elizabeth Hughes Care Unit. Elizabeth Hughes Care Unit is a nursing unit here at Harvest Hill. Currently, it functions as a transitional care unit, so people who need some extra attention for a brief period of time are transitioned into the Elizabeth Hughes Care Unit, where we can provide nursing care. It also acts as a palliative care unit. This unit has done an amazing job of providing residents with high-quality, affordable care that's consistent with their values and their goals. And we think there's a lot of opportunity to expand the Elizabeth Hughes Care Unit. Beyond expanding it, we want to also change its mission to include a unit for elders who are experiencing cognitive decline, so a memory care unit, and an adult daycare that is accessible to the local community, so that people who are caretakers for elders with cognitive problems in the community can have a place to send folks that's a nurturing, caring environment. So we think there's a lot of opportunity around the Elizabeth Hughes Care Unit. We also, since the task force finished its work, we have had an opportunity to have conversation with Dartmouth Hitchcock about the idea of an inpatient residential hospice. We know that there is interest in the community. We know there's a need, and we feel that with our focus on geriatric care, elder housing, this is a natural place for us to think about a collaborative effort with Dartmouth Hitchcock. The final thing that supports this concept of aging in place is the creation of a new product line called Continuing Care at Home. What this is essentially is a way to support elders who want to live in the community. They don't want to transition to our facility here at APD. They want to be in their own homes, but they need help. They need somebody to go to the grocery store or to arrange for a contractor to come in and do some work, or they need help with activities of daily living. A little bit of support can keep them in their homes. It also allows them to have access to the facilities and the activities that we have here at the residential facility. So we will be developing this idea of continuing care at home. All of it is building towards how do we support people as they age in place. The next task force to talk about is the multi-specialty clinic. And so what we have decided on as a strategy for the multi-specialty clinic is to build a one-stop shop. And what we realized as we went through this work was that our healthcare system is developed around what works for us. We have not put together a system that works for what works for the patient. So if you need health care, you got to go here for this and there for that, and you got to trundle up to the hospital for an x-ray and go here for the lab, and the specialist is in East Overshoe, and that's because that works for us. But we have to change the mindset to say that healthcare has to work for the patient. And we believe that the way that you do that is that you design care around what is convenient for patients. So building a one-stop shop for patients is something that we believe is critically important to the success of our outpatient clinic business. The other thing that we talked a lot about with this multi-specialty clinic is the fact that as healthcare has changed, there has been an influx into our clinics of chronic disease management and wellness checks, et cetera. And so our doctors are full, their schedules are full with things that can be scheduled, so that when the person calls with something that can't be scheduled, like I'm sick, the doctor can't see them. And that makes no sense to us. You've got to have a system that it takes care of the wellness and the chronic disease, but also can handle the acute, unscheduled stuff that comes in. What happens now is that patients, they make that call saying, I need to be seen, and it's, well, let me talk to the doctor, and maybe I can get you in, and I'll get back to you, and no, and now it's too late, go to the emergency room and rack up a big bill. What would it look like if we said, oh, you're sick? Okay, at 3 o'clock this afternoon, Dr. So-and-so can see you in the clinic. And that's the vision. That's the clinic within a clinic. In order to sort of pull this off, we really need a new medical office building. We need to have all of our services co-located in a common building. So we do intend to commission a new office building. Whether or not that will be renovation and expansion of an existing building or a brand new building in and of itself, we're not sure. But we've got to get space that allows us to consolidate. So once we have the space, then we consolidate. We believe that that is higher quality, better patient service, and also an opportunity to, by consolidating, to control costs. So we think we're hitting all three, quality, cost, and access, by really envisioning a different kind of multi-specialty clinic. The other thing that we know is that when you consolidate practices and you put the orthopods and the primary care and the women's care in the same building, it facilitates collegial conversations so that doctors are not isolated from one another, and that we think that helps to better coordinate your care. When it's hard for people to communicate, patients suffer. So by putting people all in the same place, we believe that we can improve communication. Turning our attention to the hospital redesign and the OB task force, these task forces really took a deep dive looking at our current services as well as the external environment. Again, a time of real change in healthcare. And they took a look and they said that each independently came to the conclusion that there was no path to independent financial viability. Looking at where healthcare is going and what we do, they did not believe that APD would be financially sustainable over the long haul without partnering or affiliating with another healthcare organization. They also took a look and said, if we don't do this now, it is likely that we will miss the boat. And missing the boat will put this organization at risk. The price of not acting is likely going to be financial failure of the organization in the future. So, strong message from these task forces: change is coming. We cannot independently handle that change, and doing nothing is a recipe for disaster. In light of that conversation with these task forces, we went to our Board of Trustees, informed them that this is where we were, and the board's response was to say, Sue, go out and explore potential partners and options, find out what's out there. We spent several months in conversation with different organizations trying to seek what an affiliation would look like, and ultimately came back to the board. And at the end of the day, the Board of Trustees determined that an affiliation with Dartmouth-Hitchcock Health best fit with our goals and objectives. So it was the decision of the Board of Trustees to affiliate the hospital with Dartmouth-Hitchcock. I think you've really got to step back a little bit to understand why the board sort of made the decision that they made. And so if Todd gets to the why slide, I'm going to talk a little bit about healthcare reform and where we think it's going. Our system has been built on this concept of fee-for-service. Fee-for-service means we pay you the more you do. And healthcare providers have responded by doing more. That has led to unsustainable cost at low quality. We know that the healthcare payment system has to change. And what we think is going to happen is that the payment system is going to evolve into a system that de-emphasizes fee-for-service and begins to look at contracts for managing large populations of people and being responsible for their health outcomes. So we know that you can't sort of assume, you can't impact population health if you have a small number of people. So if the payment system changes and we go to what are called risk-based population health contracts, risk meaning the healthcare organization is at risk of losing money, and health-based population-based contracts meaning that the organization is responsible for the health of a large population, we are too small to take on that kind of a contract. Dartmouth-Hitchcock is too small to take on that kind of a contract. You need large populations in order to accept the financial risk and in order to impact the number of lives that you need to impact. So you can't do this as a small organization. In fact, you can't do it as a Dartmouth-Hitchcock. What you need in order to be successful with these kinds of contracts is a large integrated network of affiliated organizations that are all coming together to improve value for patients. And we're talking about a large-scale proposition. This is not about a Dartmouth sort of taking over. It's about Dartmouth affiliating with Fletcher Allen and Maine Medical and all of the hospitals and healthcare providers in the New England region, all with a common goal of providing high-quality care at a lower cost to all of the people that live here. A sustainable health system. And so that's the vision. And as we came to understand that vision, we started to see how we could fit into it. We also really came to appreciate and understand that both the leadership at Dartmouth-Hitchcock and the leadership at APD both are committed to preserving APD as a community asset. The leadership at both organizations share a common goal, which is to ensure that this organization is successful as healthcare reform unfolds. We already have overlapping missions. Realistically, we share patients, and we routinely collaborate now. We don't do it in a formal way, and we don't admit it, but the reality is that our two organizations are intertwined. Patients know where to go. They go to APD for this care. They go to Dartmouth for that care. They don't understand why we can't coordinate that. Why, when I get my primary care here and I see a specialist up there, why can't they communicate? Why do I have to have duplicated lab work and radiology? Why can't we create a system that works for me as a patient? And so as we came to understand the benefits of affiliation, it just became clear that we all live in the same community, and the leadership of these organizations believes that it's time to bring the organizations into affiliation. There are opportunities that come with this. One is this opportunity to participate in these new risk-based, population-based payment models. As I said, got to have some money in the game, and you've got to have large populations, and you've got to make sure that you're demonstrating improved health outcomes. And so we want to be a part of that. We've got a little piece, but we want to be a part of it. We also have heard a lot about these narrow networks with Anthem and the exchange products that came out this last year. Essentially, this is a way of excluding healthcare providers from payment mechanisms. Anthem and their exchange product really didn't hurt us that much, but when Dartmouth decided to change their health plan for their existing employees, saying that APD is no longer in the preferred tier and it's more expensive to come to APD, that absolutely impacts us. And so we believe that people who live in the greater Lebanon community should have a choice and should be able to come to APD or DH, whichever their preferred provider is, and that we've got to work together to make sure that these narrow networks are not put in place, one at the expense of the other organization. I think the other thing that's really interesting and sort of at the heart of this idea is the fact that by being in affiliation, we can bidirectionally direct patients to and from the facilities. Right now, we are separate organizations and we have to behave separately. But the reality is that their facility has people in it whose needs would better be served in a community hospital. And we have people, quite frankly, who should be in a tertiary care center. But it's difficult and awkward and challenging to move those people to the right place. And so by being in affiliation, we have an opportunity to think about how would we do that? How would we be able to say, we take the community-acquired pneumonia that needs 3 days of antibiotics, and you take the person who's potentially going to go south and need an ICU bed and lots of consults. What would it look like if all the low-risk OB was done at APD and you guys just did the high-risk? So what would it look like if we did urgent care and you did emergency care? And when you start to think like this, there are lots and lots of examples. I'm not saying that any of that is the plan, but I'm saying those are the opportunities that you can start to think about. It's a win for both organizations, but more importantly, it's a win for the patients that we both serve. The other opportunity is that if you can start to think about how you consolidate back office functions, you can start to take cost out of the healthcare system. We know cost is going to have to come out, and we've got to wrestle with it. We think the best way to do that is by looking at back office functions, consolidate where we can, again, trying to provide high value for patients. Logistically, where we are with this is that in the near term, APD Memorial Hospital is going to continue as is. We will provide all of our current hospital-based and outpatient services. Our clinics are going to continue to operate. So the status quo is preserved for the near future. We are currently in the beginning phases of negotiation with the DHH leadership. DHH is Dartmouth Hitchcock Health. They are the parent of Dartmouth Mary Hitchcock Memorial Hospital and the Hitchcock Clinic. So we're talking about the parent. That's why it's DHH. What we are considering is an arrangement that is very similar to what has happened at New London Hospital and Mount Ascutney. And we can give you an idea of what's happened there. Again, we are in negotiation. We do not have a final plan, but we are basing the start of our conversation on this. What that looks like is that there is a local board of trustees. There are Dartmouth appointees to the Board of Trustees, but the local control is maintained. So at New London and Ascutney, it's 2/3 local community members, 1/3 DH. So local control at the level of the Board of Trustees. The administration, the existing administration, did not change and maintains operational control. So there was not a major change in the organization on that level. The facility maintains and retains its corporate identity and culture. It is still New London Hospital. It is still Mount Ascutney Hospital. If this goes as expected, we will still be APD. We will not become something we are not. All employees remain employees of the local organization. So there was not a sudden change in if you worked for New London, now you work for DH. You work for New London before the affiliation, you work for New London after the affiliation. And so certainly we would anticipate that that will be something that continues here. Dartmouth does retain selected reserve powers, but these operate at a very high level. They are not here sort of embedded in your operations. What they are doing is looking at things like approval of capital budget, approval of an operating budget, approval of a strategic plan, a major building project. If there was a turnover at the CEO level, they would want to have input, but they are not sort of here micromanaging the organization. That is not the model that we see. APD is a little bit unique in that we are a health system, and because we are a health system, we include life care as well as the hospital and the owned clinics. The affiliation that we are talking about does not include life care. It includes the hospital and the owned clinics. So we have to sort out, as a leadership team, we have to sort out the implications with respect to the health system and with respect to life care. So in that regard, we are unique and a little bit different from New London, but the ultimate relationship will not be envisioned to include life care. We are still actively evaluating how that all shakes out, so probably more questions than answers on that at this point. I want to circle back around to this issue of our critical access hospital designation. What's interesting is that we started on this journey in large part because of our concerns about our critical access hospital designation. What happened over the course of the last year is that this issue got a lot of attention in Congress. And about midway through last year, the Office of the Inspector General came out with a report that was very critical of sort of the entire CAH program. And they recommended de-designating 860-some hospitals. Well, interestingly, it's a bad idea to go after 864 rural hospitals, because what you end up doing is angering a lot of politicians who come from rural states. And so what happened was that Congress really got involved and beat this back. And so, interestingly, the spending bill that just went through, there's a piece in it that authorizes and mandates that CMS work with HRSA to protect and preserve rural hospitals and access to health care. So we went from sort of this giant threat to Congress very strenuously saying, we want to protect rural health. So what we think has happened is that the CAH threat sort of, it reached a peak and now it's backed off. We know that nothing is going to happen this year. We then get into an election cycle, and we all know nothing's going to happen in an election cycle because nobody's going to win an election shutting down small hospitals. So we think we've got another 2 to 3 years before this issue sort of raises its head again. We don't know for sure, but this is the story on our critical access status. One of the questions that's come up is, well, geez, if that's gone away, why are we doing this? Why are we affiliating the hospital? And I think what we learned was that healthcare is evolving. We believe that the payment mechanisms are going to change. And we believe that because payment mechanisms are going to change, delivery systems have to change. And we really believe in the vision of a sustainable health system. We want to be a part of that future. And so being a part of that future means getting involved in this concept of affiliated network of providers who are all pulling together to improve value for patients. So it's no longer about the critical access status. It really is about doing the right thing for our patients and our community. And so that's the answer to why are we doing this now. I'm going to quickly just mention the Business Health Initiative because that was one of the other task forces. The Business Health Initiative has been given another few months to figure out how they fit with this overall plan. So they're going back to the drawing board to rethink this in light of the overall direction for the organization. I anticipate that you'll be hearing more about that as the year unfolds. So just in conclusion, there are 3 sort of main points to this strategic plan that I want you to understand today. There's a lot more to the strategic plan. It's about a 3 to 5 year plan, so you're going to be hearing lots about it as time marches forward. But the 3 things to remember today, number 1, it's our intent to adopt an aging-in-place strategy for life care. How do we support people, keep them in their homes, and respect their desire to be a part of the community as they age? The second piece is how do we build a one-stop shop for patients? How do we stop designing care around us as providers and design it around you as a patient? And so we think that's a very exciting opportunity. And then the last piece is that we intend to continue to operate the hospital as a critical access hospital in affiliation with Dartmouth-Hitchcock Health. The timeline on this, elements of the Life Care and the MSC strategic plans will be implemented throughout the year. There's also complementary work in this plan that's already underway. And again, you'll be hearing more about some of those other parts and pieces as the year unfolds. As I stated, we'll have a revised BHI strategic plan sometime in the spring. And then if discussions with Dartmouth-Hitchcock Health proceed as anticipated, we will anticipate that we will submit what's called a case statement to the Attorney General sometime in April or May. The case statement is a document that we collaboratively prepare that lays out on paper why this affiliation is going to improve value for patients. So as we build that document, we will be tapping frontline healthcare providers to help us develop that argument. We file that with the Attorney General. There's a 120-day mandated public comment period. And so realistically, we expect that if the boards of trustees agree and want to proceed formally with affiliation, that would happen by the end of the year. So that's our timeline. Lots to come in this year, but I don't anticipate any finalization of the affiliation until January 1 of 2015. So thank you all for your time. Again, I appreciate you taking time out of your day. If you have questions that come up or concerns, please go to your director, find someone on the senior leadership team. We're more than happy to talk to you, and look forward to sharing more of the plan as the year unfolds. Have a great day.